So for my talk this evening, I will be covering the following. We'll do a short introduction. We'll talk a bit about the story of the BRCA genes. We'll talk about BRCA in real life, why BRCA matters beyond the individual, what we find beyond BRCA, what we do nowadays, and then the challenges we face and where we think we will be going in the future. So let's start with a number. According to the World Health Organization, in 2022 alone, about 2.3 million women were diagnosed with breast cancer, and 670,000 lost their lives to it. It is the most common cancer among women worldwide, and one that touches nearly every family in some way. But here's the key. While the majority of breast cancers, about 90 to 95%, are sporadic, driven by acquired mutations and lifestyle factors, 5 to 10% are hereditary, caused by mutations we are born with. So for ease of reference, the scientific language that we use when describing changes on a gene that causes disease is a pathogenic sequence variant. But all of you may be much more familiar with the term mutation. So for the duration of the talk, when I refer to a pathogenic sequence variant, I will use the terminology of a mutation. And that is where the story of the BRCA1 and BRCA2 genes begin. So in the 1990s, 2 genes were discovered that would change how we understand cancer risk forever. BRCA1 and BRCA2 are both genes that we refer to as tumor suppressor genes. Now I want to take a step back and take you back to your pre-med days, when some of you had very limited exposure to genetics. So let's talk about genes and chromosomes a little bit more. So genes are the fundamental units of heredity, specific sequences of DNA that encode instructions for making proteins or regulating their expression. Chromosomes are long organized structures of DNA and protein found in the cell nucleus, and they serve as carriers of the genetic information. Each chromosome contains hundreds to thousands of genes arranged linearly along its length. And we know as humans, we have 46 chromosomes arranged in 23 pairs. We have 22 pairs of autosomes, which we number 1 to 22, and then we have got 1 pair of sex chromosomes. So the karyotype I have on the screen currently is that of a female. And the way we know that is the fact that as females, we've got 2 X chromosomes, whereas males have got 1 X and 1 Y chromosome. Together, these chromosomes contain approximately 20,000 genes, and each gene has a specific chromosomal location, defined by its chromosome number and its position on the short, which we call the P arm, or the long, the Q arm of the chromosome. So for our talk tonight, talking specifically about the BRCA1 and 2 genes, BRCA1 is found on chromosome number 17, on the long arm of chromosome number 17, and BRCA2 on the long arm of chromosome number 13. Very importantly, we all have 2 copies of each gene, and that includes the BRCA1 and 2 genes. Often when counseling patients, I hear women speaking saying, do you have the BRCA gene? Yes, we all have the BRCA gene because it's got a very important job in our body. So in fact, these 2 genes aren't the villains. In their normal state, they are actually heroes in our bodies. So BRCA1 and BRCA2 are tumor suppressor genes, and the proteins encoded by these genes play a crucial role in DNA damage repair, allowing the maintenance of genomic stability. Mutations in these genes lead to inefficient DNA repair, contributing to genomic instability, and this instability leads to an increased cancer risk. The BRCA1 and 2 genes are essential for homologous recombination repair, or HRR, of double-strand DNA breaks. And this is the cell's most accurate way to fix double-strand DNA breaks. So their normal function maintains our genomic stability, while mutations in these genes predispose carriers to multiple cancers. So through years of research, we now know that the BRCA1 gene mutations are very strongly linked with triple-negative breast cancers and high-grade serous ovarian cancers. While the BRCA2 mutation raises the risk not only associated with breast and ovarian cancer, but also for prostate cancer, pancreatic cancer, male breast cancer, and melanoma. So while these are the guidelines, what we see with the BRCA1 and BRCA2 mutations and the association with specific cancers, it is always very important to take family history into account. One of the case studies I have later on during this presentation shows a family with a BRCA1 mutation where we actually see quite a number of pancreatic cancers. So we take both our genes, our mutations, together with our family history to get the full picture of what we are dealing with. So let's look a little closer into the cancer risks associated with mutations in the BRCA1 and 2 genes. So what I want to show you here, and just want to run through certain types of cancer that are associated with our BRCA genes. So we will be looking at the risk in the general population for cancers as opposed to that of a person who's got a BRCA1 or BRCA2 mutation. So if we start with breast cancer, as this is really our main topic of the night, we know that the general population risk is around about 12 to 13% for the average woman out there without a history of breast cancer. So we say we'd expect 1 in every 8 women to be diagnosed with breast cancer over her lifetime. Having a BRCA1 mutation increases your risk to 60 to 72% over your lifetime and 55 to 69% over when it is a BRCA2 mutation. And these are risks that I got from the NCCN Guidelines version 2, 2026. Looking at contralateral breast cancer, the average person out there, women's risk 5 to 10% to be diagnosed with a second breast cancer in the other breast, and that risk goes up to more than 20% for both BRCA1 and 2 positive patients. Some of them publications report risk as high as 50% for a contralateral breast cancer. Ovarian cancer, a very rare cancer, not often found in women. General population risk 1 to 2%, increases to 39 to 58% with a BRCA1 and up to 29% with a BRCA2 mutation. Prostate cancer, all men out there have got a risk of 15%, and that increases with BRCA1 up to as high as 26%. And with the latest research, we know BRCA2 mutation carriers has an increased risk up to 61% to be diagnosed with prostate cancer. Another very rare cancer, male breast cancer, found in less than 1% of males. Some publications say as little as 0.1%. With a BRCA1 mutation goes up to 1.2% and as high as 7.1% with a BRCA2 mutation. Given this and mentioning how important family history is, I, over the years, had about 3 Afrikaner families where we actually saw male breast cancers in every generation of that family, indicating that in that family, the risk could be much higher than just the 7.1%. Then looking at pancreatic cancer, general population risk 1.5%, increases to less than 5% with BRCA1, 5 to 10% with a BRCA2 mutation, and then a slight increase with a BRCA2 mutation in a patient's risk to be diagnosed with melanoma. So now let's discuss what testing options are available, because that's why we do the counseling. That's why we refer the patient to see, first of all, if they qualify for or if it is appropriate to offer them testing, but then we have got different test options available. So at Ampath Laboratory, we offer the following for looking specifically just at the BRCA1 and BRCA2 genes. So targeted testing for a known mutation. So this testing can be offered to a patient where a family member within that family has already had BRCA testing done and a mutation was identified on the BRCA1 or 2 gene. We can offer this testing if we have access to the family member's report, because we need to know what the specific mutation is that we need to look for in this patient, taking into account that there are literally thousands of mutations that has been described that can increase cancer risk in the BRCA1 and 2 genes. The next option we have is what we call our founder mutation testing. So over the years, as research were conducted in countries all over the world, it was realized that certain ethnic groups tend to have certain mutations more often than other groups. So in our the concept of South Africa, we know that there are 3 specific mutations we find much more often within the Afrikaner population. And then, of course, there are 3 very well-known mutations that we find often in the Ashkenazi Jewish people. So when we have a patient sitting in front of us who is from Afrikaner or Ashkenazi Jewish descent, we can offer them founder mutation testing. In this case, we only look at 8 specific mutations that are associated with the Afrikaner and Ashkenazi Jewish population. And this is very important to understand that this is a limited test. We, a couple of years ago, had the situation where an oncologist called us to say that we missed a mutation in one of her patients. When asking her, how does she know this? She said, no, we tested mom here, and then the daughter went overseas to the Netherlands, reported her history to the medical authorities there, and was offered genetic testing, and they actually found a mutation in the daughter, whereas mom, who was diagnosed with breast cancer here, did not have the mutation. So we asked for a copy of the daughter's report, and when we got the report, we saw that the daughter, in fact, had a mutation, but it was not one of the founder mutations. So we could explain to the doctor that we did not miss the mutation, the wrong test was done, because this is an Afrikaner person who actually has got one of the other mutations and not one of the common Afrikaner mutations. And then, of course, we offer sequencing of the BRCA1 and 2 genes through the technology of NGS and MLPA. And with the full sequencing, we will be covering both our sequence variants as well as our copy number variants. And this will then be the large deletions and duplications that we sometimes find in these genes. But BRCA is not just a medical discovery. It's a family story. Mutations in the BRCA genes are inherited and can be passed on in a family. These mutations in these genes are inherited in what we call an autosomal dominant pattern, meaning that each child of a carrier has a 50% chance of inheriting the mutation. Just to remind you again what autosomal dominant means, in an autosomal dominant disorder, I only need a mutation on 1 copy of my 2 genes, and then I will actually have the disease. In the case of the BRCA genes, inheriting 1 copy with a mutation does not mean you're born with cancer, but it means you have got the increased risk to be diagnosed with cancer over your lifetime. And that's why taking a detailed family history is so critical. So we can determine who in this family is at risk of actually inheriting a BRCA mutation. And I would now like to share 2 case studies with you to show the importance of genetic testing in the context of a family story. So my first case study, Mrs. X contacted us earlier this year in May or June 2025. Mrs. X is a healthy 37-year-old with 3 young daughters. When we met with Mrs. X and pulled the family file, we realized that she is part of a family that was first seen by us in 2011 after her mother was diagnosed with breast cancer in 2009 at the age of 56 years. At the time, 2009, mom had a unilateral mastectomy performed. And when we took the family history in 2011, mom had 2 sisters and 2 paternal cousins who were also diagnosed with breast cancer. Genetic counseling was done and genetic testing performed, and we identified that mom and both her sisters had the BRCA2 C7934 del G mutation. And this is one of the 3 common Afrikaner mutations, as did her their 2 aunts, mom's sisters, and the eldest sister of Mrs. X, who was early 30s at that time, also had testing done, and she was also confirmed to be a carrier of this familial BRCA2 mutation. In 2011, the sister was in her early 30s. She just had her first child. She wanted to have more children, and at the time, she did not do anything to deal with this risk. Then early in 2025, Mrs. X's mother was diagnosed with a contralateral breast cancer at the age of 72 years, 17 years after her first diagnosis. And she now had to have another unilateral mastectomy performed. And Mrs. X came to us because she felt she was now ready for genetic testing. So the genetic testing was performed, and it was then confirmed that Mrs. X was also a carrier of the BRCA mutation. So this is the family pedigree. This is how we then draw a family pedigree. And you will see there's a legend giving you all the cancers in the family. I've just highlighted some of them. But where the three arrows are where our index case is on the left, and then next to her sister, and then mom, who was diagnosed twice with breast cancer. So Mrs. X then informed us that she decided to immediately go the route of prevention. She decided to have a prophylactic bilateral mastectomy performed, and this was done at the end of June in the Cape. Having seen her sister make this decision, the eldest sister, who was now 47 years old, had her two children. The eldest, who was 14 now, has now decided then that maybe this is the route that she should take as well. She contacted us at the end of September this year, made an appointment to sit with me and the psychologists that I work with at the Familial Cancer Center at Femina, with her husband, just to chat through the decision that she has now made. So where in 2011, she was not yet ready to take any action with regards to her carrier status. She was now at a point in her life where this felt like the right decision for her. And since then, she had her surgery done on the 1st of October, which she thought was very appropriate, the start of Breast Cancer Awareness Month. And she is now a very vocal advocate for BRCA testing where there is a strong family history. And I'll show you a couple of slides further on. She and her sister has actually shared their story on multiple media platforms to start raising awareness. My second case study, the story of this family started in 2014 with the index case, Mrs. MJ. So Mrs. MJ came to us in 2013 after she was diagnosed with breast cancer at the age of 44 years in 2012. At the time, she had an lumpectomy performed, she had chemotherapy, and then came for counseling and testing, and we identified a BRCA1 mutation, the BRCA1C45 dupe, once again, one of the founder mutations that we test for. Following this result and pre and post-test counseling, she opted to have a prophylactic mastectomy, total abdominal hysterectomy, and bilateral salpingo ovarectomy performed. At the time in 2013, she informed all her siblings and cousins of her genetic test result, but none of them then took up the offer to have genetic testing performed. Came 2017, and that takes us to index case 2, and you will be able to see them on the next slide when I present the family pedigree. This is a cousin of Mrs. NJ who was diagnosed in 2017 at the age of 63 with triple-negative breast cancer. She then had a bilateral mastectomy performed, followed by chemotherapy, and she was advised to discuss her genetic test result with her 3 daughters, who at the time decided not to have any genetic testing done, as they were in a phase of their life where they still want to have children, they still want to breastfeed, and decided to not take up the offer, but will have testing done later in life. In 2022, index case number 3, who is the daughter of index case number 2, felt a lump in her breast. She lived at the time, she lived in Modimolle, and she had testing or a mammogram and sonar performed in Modimolle. That came back reportedly as normal, and no biopsy or genetic testing was offered to her at the time. In September 2022, she became more concerned. The lump was still there. She felt pain. She didn't feel good. And she self-referred her to a surgeon who then did a biopsy, and index case 3 was diagnosed with breast cancer. She immediately started with chemotherapy, had genetic testing done, and no surprise to us all, tested positive for the familial BRCA1 gene. In March 2023, she had a bilateral mastectomy performed, but unfortunately, in June 2023, at the young age of 42 years, with 2 small children, she passed away after her diagnosis of breast cancer. And this is the family pedigree. So case index study 1 is to the right, where the little arrow is. That was Mrs. MJ, our first patient who we tested in 2013. then index case number 2, more to the right, and then her daughter who passed away. So this is a story that not only had a huge impact on the family, because after the diagnosis and then the passing of index case 3, a lot of the family members approached us and has in the meantime had genetic testing done. Some tested negative, which took off a heavy burden of these people, because now knowing they did not inherit the familial variant, they are now at the same risk as any other woman in the general population, whereas those who tested positive could now go the route of preventative surgery. And I will come back later to this family where genetic testing did not only have an impact on the immediate family, but in this case, this family actually has an impact on the broader society. And I will refer back to that a little later on. So beyond the signs of the BRCA1 and 2 genes lies the human reality. And we've seen this play out publicly. Many remember when Angelina Jolie shared her story of testing positive for the BRCA1 mutation in 2013, and choosing to have preventative surgery. So overnight, the term BRCA entered everyday vocabulary, and that year we could not keep up with all the genetic testing that was requested. But we also know behind every celebrity headline are thousands of ordinary families facing extraordinary decisions. And on the slide on the right there is the family case study 1 that I mentioned to you, and they've given me consent to share their photo and just the heading of one of the publications where they shared the story of a double mastectomy after they received the news of having a BRCA gene mutation. And then at the left below is another family that I counseled earlier this year, where an identical twin sisters was one diagnosed with breast cancer, the other one opting to have genetic testing pre-diagnosis performed. A BRCA mutation was found, and she decided to not go through what her twin sister is going through, and she went the route of preventative surgery. So what does BRCA mean in the real life? And these are not just medical questions. These are deeply personal, emotional, and often generational questions that our patients ask. So when a patient comes to a counseling session, some of the first questions we get is, should I get tested? Specifically, if we're looking at a predictive test where I'm not diagnosed with a cancer. And then if I test positive, should I consider surgery, medication, or increased screening? And many of our patients actually come into our sessions and I ask them, have you thought about what options are available if the test is positive? And most of them often don't have a clue what can be done once a positive result is found. And then, of course, the very important question, especially for us as moms, how do I share this information with my children or siblings? So why does BRCA matter beyond the individual? It matters because as understanding the BRCA gene has changed the way, has changed medicine in 3 powerful ways. And here we will look at how it changed prevention, treatment, and family care within the context of familial breast cancer. So genetic testing is powerful because it allows a shift from reaction to prevention. When a patient knows they carry a BRCA pathogenic variant or mutation, they can act before cancer develops. And here we talk about risk reduction options. And these include enhanced surveillance. Here the idea is the earlier we detect a cancer, the bigger our chances are to actually do treatment and get a good outcome. So here we talk about earlier, more frequent mammograms, sonars, or MRIs. Often the question is asked, so when should screening or surveillance start? And according to international guidelines, screening in a patient with a BRCA mutation should start 5 to 10 years earlier than the youngest breast cancer in the family, but not younger than 25 years of age. So no, we do not test children or teenage girls for the BRCA mutation. We do not take their autonomy away to be able to decide once they are adults whether they want to be tested or not. Second is the preventative surgery. And here we're talking about prophylactic mastectomies or also doing the bilateral salpingo ovarectomies. And these options or these treatments are discussed with patients during consultation sessions. And then there is the option of medications. So for some patients, they like to discuss the option of taking tamoxifen to reduce those estrogen-driven cancer risks. But we also realize that none of these decisions are a one-size-fits-all. They must be personalized. And this is based on the individual's age, family plans, and health status. And the advice or the discussions around management will differ between a 25-year-old as opposed to a 40-year-old woman who already had her family. And this is where genetic counseling becomes essential. It helps transform a complex medical result into a meaningful, actionable plan. So now let's shift gears to patients who already have cancer and also have a known BRCA mutation. So knowing a patient BRCA status doesn't just inform prevention, it also guides treatment. And here 2 therapeutic areas stand out: the PARP inhibitors and platinum-based chemotherapy. And we can talk a bit more about the PARP inhibitors. So let's do a quick refresher on the DNA repair pathways. For some of you, this might be a first time. So we know our cells have multiple ways to fix DNA damage. Single-strand breaks are repaired mainly through the base excision repair pathway. And this is led by enzymes called PARP, the poly-ADP ribose polymerase. And double-strand breaks, on the other hand, rely on our homologous recombination repair, the HRR. And this process needs the BRCA1 and BRCA2 and other HRR genes. So what happens then in a cell with a BRCA mutation? In these cells, the HRR genes doesn't work properly. So when double-strand breaks occur, the cell then becomes dependent on PARP for survival. And here's where the magic of precision medicine comes in. If you block PARP in a BRCA-deficient cell using a PARP inhibitor, such as olaparib, you eliminate the cell's backup repair pathway. The DNA damage in that cell piles up, the replication forks collapse, and eventually the cancer cell will die. The healthy cells, on the other hand, still have working BRCA genes and they can survive. So this is known as a synthetic lethality, a beautiful example of turning a genetic weakness into a therapeutic strength. And as you will probably be aware, PARP inhibitors are approved for BRCA-mutated breast, ovarian, prostate, and pancreatic cancers. And nowadays, we often get referrals for genetic counseling for patients where the doctors, actually the oncologists, request BRCA testing to determine whether PARP inhibitors could be used as a therapy. I recently had a male breast cancer where he was referred for BRCA testing because his breast cancer did not react on the chemotherapy that was given to him. So we are currently in the process of testing for the BRCA gene mutations, because if he's got a BRCA mutation, they can then consider changing his therapy to PARP inhibitors. So one of the most important things to remember is that BRCA test is never just about one person. A positive result carries implications for parents, siblings, and children. And that's why cascade testing, where we offer genetic testing to relatives of a known carrier, can actually help protect entire families. Discussing these risks can be emotionally complex, and genetic counselors play a vital role in helping families to navigate these conversations, deciding when, how, and whom to tell in the family. So what do we mean when we say, let's talk beyond BRCA? So we know the genetic landscape changes very quickly and it has expanded. So while the BRCA1 and 2 genes are the most famous and the 2 genes mostly associated with our hereditary breast ovarian cancer syndrome, they're far from the whole story. Other genes like PALB2, CHEK2, ATM and TP53 are also associated with hereditary breast and ovarian cancer syndromes. And some carry risks comparable to the BRCA genes, while others confer a more moderate risk. So broader multi-gene panel testing now offers us a more comprehensive understanding of breast cancer risk, by evaluating multiple genes simultaneously, which enhances risk assessment beyond the traditional single gene test like BRCA1 and 2, especially when a BRCA testing alone is negative. So today, multi-gene panel testing can evaluate dozens, if not hundreds of genes simultaneously, offering a broader and more precise picture of inherited risk. There are both advantages and some disadvantages to testing multi-gene panels. So I just want to discuss some of these advantages and then also talking towards variants of uncertain significance. So we know broader gene coverage can be found if we do a multi-gene panel. So we now analyze these dozens to hundreds of genes simultaneously, and now we can include those genes associated with our moderate and low penetrance risk. And now we're not just linked to or can only look at our high-risk genes. We can identify additional risk factors by including genes linked to other hereditary cancer syndromes, such as Cowden syndrome, Lynch syndrome, Li-Fraumeni syndrome. Multi-gene panel testing can provide insights into an individual's risk for various cancers and not just breast cancer. There's also the increased mutation identification that we get from multi-gene panel testing as we now look at a wider array of genes that are associated with breast cancer. And then one of the things that sometimes make multi-gene panels difficult when it comes to interpretation is the detection of what we call variants of uncertain significance. So variants of uncertain significance are those changes that we find on a gene that with our current knowledge, we just do not know enough about these changes and we do not have enough information to be able to determine whether these changes can actually cause disease or not. And then we call them variants of uncertain significance. And some of the laboratories do report on these variants of uncertain significance. And these findings can complicate risk assessment and management decisions. As the clinical significance is unclear, it can cause anxiety in a patient. And in a genetic counseling session, we talk a lot about finding these variants of uncertain significance. Genetic testing is quite a costly test to do. And then coming back to a patient without having discussed this with them before getting a result and telling them, we found something, but we're not totally sure at this time what it means, is really not a good way to start giving a result back to a patient. So we discussed that there is always a chance to find these variants of uncertain significance and to remind a patient that we cannot make any clinical management decisions on a variant of uncertain significance. We do know from research and the international databases that the majority of these variants of uncertain significance in the future will be reclassified as benign or negative. And the figure given at this point is that almost up to 90% of these VUSs will be reclassified as negative. But despite all these advances, several challenges remain, and I will discuss some of these challenges in the next couple of slides. So first of all, looking at access and equity. Not everyone who should get tested does. And the reason, therefore, can include reasons such as barriers to cost, geography, and limited health infrastructure, which persist, especially in low and middle income regions. So at AMPATH, we've partnered with the Marlene van Staden Breast Cancer Awareness Foundation, shortly known as Angel M. And this is a non-profit founded in honor of one of our patients whose family we've been on a journey with since 2013 to sponsor both genetic counseling and testing for those in need. So this NPO started as a result of case study number 2 that I shared with you earlier. Marlene van Staden, who was case study index patient number 3, was the mayor of Modimolle for many years and lost her life after testing for the known familial mutation was postponed until she was diagnosed with breast cancer. And working together with this NPO has been a powerful reminder that progress must be paired with compassion. So Angel M is now there to help patients in need who cannot afford genetic counseling and testing. So testing is then offered to patients who has got a strong family history of cancer, who cannot afford the testing, and the way in which it works, and you can take our telephone number, our email addresses for future reference. is patients are referred to us for genetic counseling, and genetic counseling is seen as a prerequisite before Angel M will pay for any genetic testing. And they can then contact us at the Empathy Genetics Clinic, where we will then start the process. During the genetic counseling process, we will take the full family history, we will discuss the non-profit organization, and we will get the consent of the patient to just share their name with Angel M, as this is needed to be able for them to consent to the testing and paying for the testing and the counseling. Angel M does not have access to the patient's results at all, and that is just to show you one family where doing BRCA testing changed the lives of so many families within that family, or family members within that family, has now reached out, and they are really helping quite a number of our patients to get access to genetic testing. So some of the other challenges we face is knowledge gaps. And here we're going to talk a bit towards testing criteria, result interpretation, management, education, and equity. So many clinicians underestimate which patients meet the criteria for BRCA testing. And studies show that a large proportion of eligible patients are never referred for genetic counseling and testing. One such study in the USA found that only 20 to 30% of breast cancer patients who met the NCCN criteria were appropriately referred for BRCA testing. And these reasons, therefore, are certain misconceptions, and these include believing that BRCA testing is only indicated for women with a strong family history, missing those cases where there's a limited family structure or paternal inheritance. And I always tell the patients we are limited by what we know about our family. There's also the under-recognition of paternal transmission of BRCA mutations, and then there's uncertainty about whether we should test men or patients with pancreatic or prostate cancer. If we get to result interpretation, this can include confusion over the variants of uncertain significance, which we've already discussed, or negative results, and even understanding in what gene a mutation in that report was reported. So many providers, healthcare providers, are unsure how to interpret or communicate results where we find variants of uncertain significance, and this can then often lead to unnecessary interventions or anxiety. There's also the need to distinguish between germline versus somatic results, and it's important to not misinterpret a somatic BRCA finding with a germline finding, as this can affect the patient management and family counseling. There's also this misconception that a negative test result always equals no risk to a family. And we do know that we have got families where we've got very strong histories of breast cancer, ovarian cancer within the family. We do our multi-gene cancer panels and then still don't get the answer. This is not truly a negative result, because we need to take the history into account, and we need to consider that we might be looking at genes that we have not analyzed. We might be looking at not testing the right person in the family, so there are many reasons therefore. And then looking at education, we know that genetics is often only a very small part of medical training, and this can also add to under-referral. And then, of course, equity. Majority of research until recently has been going on in the Western population, and there's a lack of variant data for diverse populations. So my next two slides, I would like to share one more case study with you to demonstrate the importance of interpreting a result correctly. So Mrs. L was a patient of mine who I saw for the first time in 2020 after she was diagnosed with breast cancer, having had a previous diagnosis of colon cancer in 2013 at the age of 51 years. So what we did then, we offered her overseas testing for a bigger panel of genes, because looking at the breast and gynae cancer guidelines-based panel, we included both the genes for the hereditary breast ovarian cancer syndromes as well as our colorectal panels or genes. And then this result came back as negative. In 2023, she was referred back to me by her oncologist, asking us to please do a multi-cancer panel where we look at 70 genes on her, as she was now at a stage where she had metastatic disease in her lungs. And there is a snippet of the result that came back after we did the multi-cancer panel. So what you will see is one pathogenic variant identified in the RECQL4 gene, which is associated with autosomal recessive Rothman-Thompson syndrome, Rapidolino syndrome, and Wöhler-Gerald syndrome. What you will see, what I highlighted in the red there, is the result does not say positive, it says carrier. So this gene is associated with 3 diseases that are inherited autosomal recessively. To give you just a recap back to your genetics many years ago, autosomal recessive gene disorder, I need a mutation on both copies of that specific gene before I will actually present with the disease. In this case, if you look there in the red where it says zygosity heterozygous, Mrs. L only had a mutation on 1 copy of her gene, and therefore she did not have disease, but she was a carrier for these diseases. This result did not explain the breast and colon cancers that were seen in this family. So we could not give them an answer with regards to their risks. So earlier this week, we had a call from Mrs. L's eldest daughter's doctor, who reported that she counseled the daughter, who was now age 28, with regards to a prophylactic mastectomy because her mother had a positive BRCA result. And she wanted to know from us what should she request, and we asked her to please send us the report of mother, and then my patient's report came through, and we realized this patient of the doctor was actually my patient from 2020 and 2023's daughter. And this mom did not have a BRCA mutation. So we contacted the daughter and discussed with her that I saw her mom twice previously, the last time 2023 when mom was quite ill. And through our discussion, she informed us that her mom has passed away in May this year. When I look back at the report, what we did was, when I wrote back my report to the oncologist after the multi-gene cancer panel report was out, I wrote there that mom reported that she will decide if and when she discusses her results with the daughter. So I asked the daughter whether their mother discussed her results with them, and the answer was no. After mom passed away, the daughters found this report, and this is now where all this anxiety is coming from. So we now have a consultation set up with the 2 daughters to discuss their mom's result and explain everything to them. So once again, just showing the importance of interpreting a result correctly. But there's also a human side to genomics. We can't talk about BRCA without acknowledging the emotional landscape it creates and the emotional burden that goes with this. Knowing that you carry a BRCA mutation does not only have profound medical implication, but it also comes with significant psychological and emotional challenges that may persist across the lifespan. And these challenges often emerge at several key points in a person's life. First of all, during genetic testing, then upon the result disclosure, when making surveillance or surgical decisions, and then through family communication. So a positive result often brings feelings of anxiety, fear, and anticipatory distress. There's the fear of cancer development, and this is one of the most immediate emotional reactions after receiving a positive result. Carriers often describe a ticking time bomb feeling that they experience, knowing they have a high lifetime cancer risk, but are asymptomatic. And anxiety often peaks around the screening intervals or before prophylactic surgery. So very often our patients tell us, when the time comes when I have to go and have my mammogram, I am so anxious that I don't know what to do with myself. And then many of the patients experience hypervigilance to bodily sensations and repeated uncertainty-related distress. So there's often the question not when will it happen, or they will think, when will it happen, rather if this will happen. So a lot of fear, anxiety, and distress often goes with doing a BRCA gene test. So also what we see, looking at the emotional burden, is decisional conflicts that arise. And patients start asking questions about body image, fertility, and regret. So unfortunately, when we look at preventative decisions, these are not easy decisions to make. We talk about women making decisions whether to go for a prophylactic mastectomy or not. And where some patients report long-term satisfaction with their risk reduction option, others struggle sometimes with surgical regret or altered sexual identity. And here it's very important for a patient to have a good support system. And then many carriers grapple with guilt. And then this often causes family and interpersonal stress. So patients feel guilt towards family members. Many feel responsible for passing on the mutation or feel anxious about their children's risk. More often than not, when I get a woman sitting in front of me, one of the first things she tells me is, I'm not here for myself, I'm here for my children. Because moms are fearful of the chance that they might have passed on a BRCA gene mutation to their children. And something we try to get across to these mothers are, we have got no control over the genes we pass on to our children. And then, of course, family communication challenges include deciding when and how to tell family members. And some families experience tension, blame, or avoidance following disclosure. We get families who don't talk to each other. And that's quite sad because then this genetic information is not shared within the family. And then some women experience gendered burden, where the women in the family often become the information managers, shouldering the responsibility to inform and advocate for relatives testing. So I always tell my patients that your only responsibility is to share your genetic result with family members. And what they decide to do with that result is their choice. It is not your job to make sure everyone in the family gets tested, because that's a personal choice that every person must make for themselves. And then, of course, it has an impact on identity and self-perception. So knowing that you're a carrier of a BRCA mutation may alter your self-concept from healthy to high risk or precancerous, and some even see themselves as permanent patients. And this can then often disrupt the plans for relationships, fertility, and future family planning. And then there is hope, because emotional adaptation happens and it improves with access to genetic counseling, access to peer support groups. And this is very important. So over the years, we've gotten a group of patients together where young women who've gone through the whole process of doing genetic testing after seeing their mother pass away from cancer, going the route of either preventative surgery or increasing surveillance. And they are now available to chat to newly diagnosed patients or to patients who's recently been tested and found to be carrying a BRCA mutation. So we have got a list of names and we give that to our patients, and they then at their own time can actually contact these support groups and chat to them. Because walking in someone's shoes is the only way you really know how to support them fully. Then we can offer them psychological interventions that focus on coping and decision-making. And over time, what we experience is that many carriers show psychological resilience and find empowerment through proactive health choices and family protection. And then we see fear that is transformed into empowerment. So where are we headed? What is the future looking like? So we're looking more towards integrated care, where genetics will be part of everyday healthcare. We're talking about personalized prevention, where genetics will guide screening schedules and tailor treatment. And then we need to expand the global reach. Advances must extend to every corner of the world and not just in our high-income countries. So beyond BRCA means using the full power of genomics to reimagine how we prevent, detect, and treat cancer. And I want to leave you with this thought. When we say cracking the code, it's not just about DNA. It's about cracking the code of fear, silence, and uncertainty that cancer has carried for generations. The BRCA story shows us that knowledge is not just power. It is prevention, it is treatment, and it is hope. I thank you for your time.